Hi, thanks for watching Administering Medication to Children. Today we're going to go over just some of the key points when giving medication to children. Some things to think about around pharmacology and children. Doses are based on a child's age and weight, or sometimes body surface area. Developmentally or physiologically, infants have immature liver and kidney function, and so that can affect how medications are absorbed. It can also affect how toxic medications can be to kids. They also have an immature blood-brain barrier, and so might experience more neurologic effects from medications. Infants and children also have decreased gastric acid production and slower gastric emptying time, and so that can affect how oral medications are absorbed. And then kids also have a higher body water content, and so that can affect the dilution and absorption of medications. Thinking about some things to assess prior to giving medications, of course looking at allergies and food allergies, determining if the medication dose is appropriate for the child's age and weight, and we'll talk more about that process. Looking at the child's developmental ability, so you will need to tailor your approach to the developmental ability of the child, as well as their physiologic and psychologic condition. So if they're very anxious, very ill, whatever it might be, you're going to need to take that into consideration when giving them medication. And then if you're giving an injection or subcutaneous or topical medication, we'll need to look at tissue and skin integrity, and then IV patency when looking at administering an IV medication. Some of the topic areas we're going to look at in the remainder of our time together are developmental considerations and safety considerations, and then giving oral, G-tube, IM, and IV medications. So first off, with developmental, the safe dosage range is our calculation that we're going to do to determine if a medication dose is appropriate for the weight of the child, and those ranges vary by the age of the child, so you'll need to know both the age and the weight in order to determine the correct calculation to use, and then you'll plug the child's weight into that, and we'll practice that. Thinking about your administration technique, so for oral medications, infants are going to be at a higher risk for choking. Young children probably can't swallow pills. You'll have to take that into consideration. For IV medications, children have more vulnerable veins, and so are at higher risk for infiltration and phlebitis, things like that. For giving injections, they have smaller muscle mass, and their subcutaneous and fatty tissues are distributed a little bit differently, and so you'll need to be aware of those things when giving injections. Using distraction is a huge part of giving medication to children, and you're going to need to figure out an approach that either makes it a game or something fun, or they're watching a video involving the parent, whatever it might be, so that you can better elicit their cooperation. Choices is another thing that you want to think about. If you ask a child, do you want to take your medicine, you're kind of giving them a choice, yes or no. Chances are they will say no, and so you do want to be a little savvy with the choices you give them. Maybe you want to say, would you rather take your medicine in this little cup or this little squirter? And give them the choice between a med cup and a syringe. Would you like me to give the medication to you, or do you want your mom to do it for you? Or do you want to do it yourself? So thinking about what those choices are. Do you want juice after your medicine, or a sip of water, or a popsicle? Relating to that, you want to set limits. So I find that sometimes people will say, if you take your medicine, then, I'll give you a reward, or whatever it might be. We can go to the playroom. The if you might want to think about avoiding and instead use when. We want kids to recognize that taking the medication is not an option. They have to do that, but that there's something fun that will happen once they do it. So when you take your medicine, then we'll go do this awesome game, or whatever it is. Kids are often more cooperative if their families are involved, so if you can think of a way to involve the parents or siblings in the game of giving medication, that is wonderful. And then rewards or incentives, or we'll just call them bribes, stickers, game time, little prizes, whatever it might be, can be great options to motivate kids to take their medication. There's lots more developmental things to think about, and you can see more of those by age group in Table 35.1. All right, now on to safety considerations. Giving medications to children does have a higher potential for mistakes and errors, and so we do want to be extra cautious and extra attentive to safety considerations when giving medications to kids. Thinking about those 6 rights, your textbook also adds a couple of extra ones: the right to be educated and the right to refuse, but for the most part there's the 6 rights of the right medication, patient, time, etc. And then confirming with 2 patient identifiers. So for an older child, you can ask them to state their name and birth date. For younger children, we'll be doing that off of their ID band in the hospital. So you'll be looking at their name and probably their medical record number as the 2 most commonly used identifiers in the hospital for kids. Don't abbreviate. So medications that are abbreviated can be confusing. The abbreviation MS can stand for a variety of medications, morphine sulfate or magnesium sulfate. We don't want to get those 2 mixed up, so don't abbreviate. And then do know that there are different concentrations of medications. For example, amoxicillin, Tylenol, they all come in a variety of concentrations, and so we want to look at both the milligrams as well as the volume of medication that we need. If we just say we need to give a teaspoon of medication, well, that might vary depending on how much medication is in each teaspoon of medicine. And then some safety things to think about when you're writing out doses. We never want to have a trailing 0 after a decimal, so that 2.0 could be mistaken as 20. And so we want to avoid that. The same with leading a decimal with a 0. We always want to do that. 0.1 without a 0 in front of it could be easily mistaken as 1. And these rules will apply to any medication calculation test that you take. You will need to abide by those. And then estimate your answer before you make the calculation. Do you have a ballpark idea of what that answer is going to be? And then once you have the answer, look back. Does it make sense? Then going on to rounding. So rounding is at the nurse's discretion. You do need to make your best choice as to how to round a medication or a weight or a number in pediatrics. So some rules: pediatric weights should be recorded in kilograms and go to at least 1 decimal place. More decimal places if it's an infant or a young child. For medications, thinking about how you can accurately deliver the dose. So if a dose is under a milliliter, you can use a mil syringe and go down to 2 decimal places. If a dose is over a milliliter, the smallest increments you can use are 1 decimal place increments on those syringes, and so you would want those doses to be to 1 decimal place. And then if you're going to round, do it at the very end of your calculation only once, so that you're not rounding multiple times and causing your answer to be skewed. Okay, so let's practice a little bit with oral medications. So we have Ella, who's 7 months old, and she weighs 8 kilograms, and she is diagnosed with an ear infection, is going to get amoxicillin, 350 milligrams orally twice a day. Our safe dosage range that we look up, we can find that for otitis media, the safe dosage range is 80 to 90 milligrams per kilogram per day in divided doses. And so we want to plug her weight into this equation. And so we're going to take her weight of her weight of 8 kilograms times the 80 milligrams per kilogram per day as the low end, and that's going to give us 640. And then we're going to take her 8 kilogram weight times the high end, which is 90 milligrams per kilogram per day, to get 720. And again, this is for the whole day. So our options are to either take her dose and multiply by the number of times she's going to get that in a day, so 350 times 2, or we can divide our calculation by the number of doses she's going to get. So going with that first, if we take 350 and take it times 2 doses that she's going to get a total of 700 in a day, and so that falls within that daily range. Or we can take 640 and divide it by 2, so that would give us 320, and then 720 divided by 2, That would give us 360, and so then we can see that our dose is 350, which falls between the 320 and the 360, which would be the range per dose. Then going on to some calculations relating to the volume of medication to give. So we have a same child who's getting 350 milligrams of amoxicillin, and our concentration that we have is 250 milligrams per 5 milliliters. And so we want to figure out how many milliliters do we need to deliver the dose. So thinking about a prediction that we could make, we might ask ourselves, is our answer going to be higher or lower than 5 milliliters? Well, we know that 350 is bigger than 250, so when we finish, we should be a little higher than 5 milliliters for our answer. So then we're going to take 5 milliliters over 250 milligrams times our dose that we need to deliver. I always like to simplify that down, so 5 goes into 250 50 times. And so we're going to take then 350 and divide it by 50. So let's just do that. So 350 divided by 50. And there we have our volume, so 7 milliliters. And so we look back. So we had predicted that would be a little over 5 milliliters, so 7 does seem reasonable. And then that volume might change depending, again, on what our concentration is that we have our dose available in. So here's Ella. How do you think we're going to get this dose into her? Babies don't always love to take medicine. So, of course, we want to check our identifiers. She's not going to tell us if she's not Ella, that we don't have the right medicine, whatever. So we have to be very attentive to confirming her identity. And then thinking about the best way to give it. Sometimes people will want to mix the medication into a bottle and give it that way, but that is not a good idea because now Ella has to, instead of taking 7 milliliters of volume, needs to take 4 ounces of formula with 7 mils mixed in, and it probably changed the taste of her formula or breast milk, and so she will hate it. So that is not a good strategy. Instead, use a syringe, and then we want to hold Ella, or have the parent hold Ella, kind of cradled with her head elevated. Try to use your arms or the parent's arms to kind of secure hers, because you really don't want her hands in her face. That's going to make it a lot more complicated for you to get the medication in. And then take that syringe and just do a little squirt in a cheek pocket. Give her a chance to swallow. I find that it helps if you kind of pucker up the cheeks a little bit so that they can't spit it out instinctively. And then have a pacifier ready to go if the baby likes a pacifier, so that you can give a little medication and then put the pacifier in so that they kind of suck on that and swallow the medication. And then you keep repeating that until the medication is gone. They do have some devices, specialty devices, that are pacifiers that you can put medication in and then give the medication that way, and some babies love to take it that way. And so those are some ideas. Here's a little older of a child, so maybe a preschooler or early school age. So thinking about how your approach might be different now for an older child. I'm not sure that medication on the spoon is going to work. You might try a little cup or that little syringe. You got to turn this into a game, right? Thinking about choices you can give her, distraction techniques, involving the parent, all those kinds of things to get successful cooperation. But you might have the idea that giving medication to children is going to take a little more time than giving medication to a cooperative adult. Moving on to G-tubes. So Mickey buttons are the most common G-tube that kids will have. This is a low-profile device that once their tract is established, then they can have the Mickey button put in. And then you can connect and disconnect that extension tubing so that you can give medications or feedings. So just some general tips. You'll always use the oral medication safe dosage range for calculating the range when giving a medication via G-tube. And then thinking about water flushes. So we don't give quite as much water with medications to kids just because those can be large volumes then. Ideally, just a little bit of water in between each medication and then enough water at the end to really clear out that extension tubing in the Mickey button itself. So maybe 5 to 10 milliliters. Ideally, we would not mix medications. Some families have been giving medications for a while and will mix them. But in the hospital, it is preferred that you do medications individually. That way, if a medication gets accidentally wasted or something happens, you'll know. And then also, some medications can clump together and clog G tubes, so that's another reason to not mix them. Some considerations for giving IM medications. So the vastus lateralis, that big muscle of the thigh and upper leg, is the preferred site for infants. The dorsogluteal, one of the muscles in the back of the butt, is not used, and that is because that muscle does not develop until a child is walking. And there's that really big nerve that goes back there, the sciatic nerve, and you're more likely to hit it because their muscle mass is so small and can cause permanent nerve damage. So we do not want to use that muscle at all. Ideally, we'd like to avoid injections into the butt for kids if at all possible, just because sometimes it's associated with a punishment, and so we don't want that misconception. And then kids' muscles are smaller, and so it would make sense that the volume of medication that you can inject into a muscle is going to be smaller. So for infants, just a 0.5 ml, and then moving up to 1 ml, 1.5 mils for an older child, and 2 mils for a teen. So if the volume of medication exceeds the max volume per injection, you do need to split your volume into multiple injections. We always want to think about numbing the site first before giving an injection. Pharmacy can dilute the medication with some lidocaine, and that can help to ease some of the discomfort. And then thinking about ways that we can ease that discomfort as well. So for infants, the use of sucrose, a little bit dipped on the pacifier, that's a great pain management strategy for infants. And then thinking about distraction and comfort holds for all other kids. We don't want to hold kids flat on a surface to give an injection because they really have a sense of being out of control. So thinking about how you can sit them up, use a parent to give that injection. So here's another calculation. A child is diagnosed with pneumonia and is getting a one-time dose of ceftriaxone IM. The safe dosage is 50 to 100, so we could quick do that since it's a one-time dose. This child is going to get the max volume for that day, so 6 times 50 is 300, and 6 times 100 is 600, so the most that they could get in a day is 600, and we're giving 500, so that looks good. Now we have the 1 gram per 4 mils. So here's another opportunity to practice. Are we giving more than a vial, less than a vial? We're giving less. And then we can probably think this through in our head. 500 milligrams is half of 1 gram, which is 1,000 milligrams. So we're going to give half of a vial, which is 2 mils. So you can practice running that equation through if you need to. Now we have an infant, and we have a 2 ml dose. So this is, depending on this, how much muscle mass, this is somewhere between, 2, 3, maybe 4 injections in order to get that dose delivered. So it's not a fun time for sure. I usually do this with another nurse so that we can each give some injections kind of simultaneously, and then the parent can hold the baby and try to get it done with as quickly as possible. Still using that sucrose, comforting the infant, numbing that site, and then giving medications via IV. We do need to figure out dilution, so a lot of the times in the hospital, the pharmacy will figure that out, and as the nurse, you just need to confirm it. So we don't want to give medications too concentrated through an IV, or it's going to be very irritating to their veins, so making sure that it's appropriate diluted. And then the rate, we don't want to give medications too fast, right, or you're more likely to experience side effects. Compatibility, if they're having other infusions going. Syringe pumps is something that we commonly use in pediatrics because the volumes are so small. So we're not going to give a huge piggyback bag of medication. We might just give a 5 or 10 milliliter syringe of medication. And so we're going to use a syringe pump that hooks into the IV line. And you'll get the opportunity to practice with syringe pumps in the lab. And you'll see them in your pediatric clinicals. And then some things to note, the IV sites, you're going to look for your biggest vein, and sometimes those are in the scalp for infants, especially if they don't have a lot of hair. It can be a little bit alarming for parents, but it's not going to damage the brain at all. It just is going on the surface there of the skin right above the skull. Because their veins are more fragile, the minimum assessment is every hour, and more frequently if there's anything concerning about an IV. And then, of course, we want to protect an IV. Younger kids don't understand why it's there, and their instinct is to pull it out, kick it out, whatever. So we do want to stabilize it and secure it well as needing to be able to see it. We don't want it so wrapped in tape or other things so that you cannot see the site, because it will be more likely then that we won't catch it if it starts to infiltrate. Okay, so then looking at calculation, so where I have a child who's in the hospital and is going to get cefotaxime 500 milligrams every 6 hours. We have the safe dosage range and we'll practice calculating that. Our minimum dilution is 100 milligrams per milliliter. And our dose comes from pharmacy as 500 milligrams in 5 milliliters. So that meets that minimum dilution. So we can just confirm that. If it wasn't diluted enough, we would need to add additional fluid. If it was diluted beyond that, that's okay. That's just the minimum amount. So if it was just 250 in 5 mils, or no, 500 milligrams in only 2 mils or something like that, then we would need to add more volume to that. So here's the equation for how you set that up. You have your milliliters on top over your milligrams that's in that dilution, and then take that times the dose and see what the minimum dilution is. And here's an example of a syringe pump. These are the kind that are used at Children's. And so we do need to figure out the rate. This is programmed independently of your infusion, so it's not like a piggyback. And we want to give this over 15 to 30 minutes is what the drug guide said. So we're going to pick 30 minutes as a practice. And again, remember we have 5 mils, so our dose is in 5 mils. So that's the volume that we need to deliver over 30 minutes. So we're looking for milliliters per hour. Right now we have 5 mils that we want to deliver over 30 minutes. So we want to convert that to an hour. So that's 60 minutes in an hour. Again, I always like to simplify that. So there's 30 minutes goes into 60 minutes 2 times, which makes sense. There's 2 30-minute increments in an hour. So we're just going to take our volume of medication times 2. That's going to give 10 milliliters an hour. If we're running at a rate of 10 milliliters per hour in 30 minutes of time, 5 mils will have gone in, and that is our ordered dose. And then we will program on a flush at that same rate. And we'll practice this calculation with different time frames. Another type of calculation is NG replacement. I think that you've probably done this before. So for example, you have a child who has an NG dissection and has maintenance fluids going at 100 milliliters an hour. And we're going to replace NG output milliliter for milliliter with a different solution, normal saline, over 4 hours. So this child is going to have 2 pumps going, one for maintenance and one with a bag of normal saline that every 4 hours we're going to adjust the rate, depending on how much output she's had from her NG. So to figure out this current amount, we're going to take the total amount she had out at noon, which is 120, divide that by the 4 hours that we want to replace that over, and that's going to give us a rate of 30 milliliters per hour. So that's going to be our rate for the next 4 hours. Our volume to be infused is going to be that 120. So once it's reached that 120, it's going to beep at us, and we're going to come in and remeasure that NG output and do our calculations all over again. Something that is sort of similar is an IVPO titrate order. So what this is, order that allows us to do is we have a goal for fluid volume over a set amount of time. And we need to meet that goal either with IV fluids or oral fluid intake. And so if an infant is feeding well, we can decrease their IV rate. Or conversely, if they're not feeding well, we can increase that IV rate so that we're meeting those fluid needs. So here's a sample. An infant has an IV PO titrate order of 240 milliliters every 4 hours. So that's our goal. We're going to use how she's been feeding in the past to kind of predict how she's going to feed in the future. So in the past 4 hours, she had 2 ounces. Now we're going to use that amount to figure out what our new rate is for the next 4 hours. Okay, so let's go on to the next slide and then work through that calculation. So again, our order is 240 milliliters every 4 hours. We know that in the past 4 hours, she's had 2 ounces. And the conversion for ounces to milliliters is one that you'll need to know. For every 1 ounce, there's 30 milliliters. And so 2 ounces would be equivalent to 60 milliliters. So what we're going to do is we're going to subtract that off as volume of that 240 that she's already met. So we're going to take 240 minus the 60 milliliters. That's going to give us 180. That's about what we need to anticipate we're going to need to give via IV. So we're going to divide that by 4. And that gives us a new rate of 45 milliliters per hour. With IV PO titrates, you can never exceed the max rate to deliver the 240 in 4 hours. So if she wasn't drinking anything, the max amount that she could get is 60 milliliters an hour. That's her max rate. We'll never go above that. We'll just decrease that rate as she's eating well. And again, this is not going to be as precise as an NG replacement because we're using her past intake to kind of predict how she's going to do in the future. So if she's going to sleep or she's becoming MPO, then we're just going to go with the full 60 milliliters an hour. Or if she's just waking up and we're going to turn it down, anticipating that as she wakes up in the morning, she's going to become more hungry and want to bottle, we might kind of anticipate that and turn the rate down a little bit proactively. So this is something to just kind of have some good understanding about how to kind of use this order to kind of anticipate based on how the infant's been doing. Okay, and then thinking about your maintenance fluid calculations. So again, we talked about infants and children having a higher percentage of water in their body. That is something that plays into our fluid calculation. So the younger the child, the smaller the child, the higher the concentration of fluid is per kilogram. So as they get older, that ratio is going to decrease a little bit. So this just kind of shows you the 3 steps. This is a formula that you don't have to memorize. You just need to know how to use it. This formula is the only formula that would be given to you on an exam or medication test. So for the first 10 kilograms, we're going to use a ratio of 100 milliliters per kilogram. If a child weighs more than 10 kilograms, somewhere between 11 and 20, we're going to take that 1,000, which is for the first 10 kilograms, and then the ratio for the kilograms over 10, but not up to 20 yet, is going to be 50 milliliters per kilogram. And then if a child is over 20 kilograms, it's going to be the 1,500 milliliters. So that's the 1,000 for that first stage, the 500 for the second stage, and now we're going to go with a ratio of 20 milliliters per kilogram for each kilogram that's over the 20. So an important thing to keep in mind is that this ratio is not for their entire weight. So some of that weight is already replaced in that initial volume. So I know we're going to have to practice this a few times in order for it to make sense. So let's go ahead and practice for a baby. So we have an infant who weighs 5 kilograms. So across the top there is our ratio. For the first 10 kilograms a child weighs, we're going to do 100 milliliters per kilogram. So this one is the easy one. We take a 5 kilogram weight. We take that times the 100 milliliters per kilogram. That's going to give us 500 milliliters. Now that is the volume that a child would need in a day. This does not account for any extra fluid needs if the infant is vomiting, diarrhea, high fevers, breathing fast. Those fluid needs are going to be higher than that. This is just maintenance, so what they would need to just maintain their normal function. These calculations are kind of like the safe dosage calculations for medications. This is the calculation for the safe dosage for fluids. So this is how you check and order that you have for fluids. You wouldn't use this calculation to figure out what to set your rate at, just as a comparison for what the ordered rate is. Okay, and then since we are programming our pumps in milliliters per hour, then we would divide that daily amount by the number of hours in a day, so 500 divided by 24. That's going to give us an hourly rate of 20.8 milliliters per hour. And then that's what we'd anticipate. So we would look at our orders and see what that ordered rate is for the infant. If it's 25 milliliters an hour, well, we know that the child must be having some ongoing losses. If it's only 10 milliliters per hour, that tells us that, oh, this baby's going to need to really be bottling in order to meet their fluid needs in a day. IV fluids alone are not going to do it. Okay, then moving on to the next stage of that equation. So if we have a child who weighs somewhere between 11 and 20 kilograms, this is the formula we're going to use. So we're going to use an example of a child who weighs 15 kilograms. So for the first 10 kilograms of their weight, we're going to use that 1,000 milliliters. So that 1,000 milliliters is a set number. Now we're going to add that to our new ratio of 50 milliliters per kilogram over 10. So we have to figure out how many that is. So 15 minus 10 leaves us with 5 kilograms that we need to calculate at that new ratio. So we're going to take 5 kilograms times 50 milliliters per kilogram. That's going to give us 250, and we add that to the 1,000. That's going to give us 1,250 milliliters in a day. I did not label that, so that's not as clear. Then we can take that number, divide it by 24 hours. And you can see 52.08. So it might be 52.1, but for IV fluids, we might kind of just go to kind of more whole numbers. So 52 would probably be a reasonable rate. Even 50, something like that would be fine. So then the last equation is for children who weigh over 20 kilograms. So we'll do this one as a practice question. And then just know that this was just kind of a 30-minute introduction to giving medications to children. You're going to have a lot of time in lab to practice all of these calculations. There are additional online video tutorials if you want to go through some of these types of calculations in more detail. There's practice worksheets, there's lab TAs, there's just a lot of resources that you have for further practice with medications. So don't feel overwhelmed. You'll get the hang of these. Thanks so much.